Good morning and welcome to a second meeting of the Citizens Participation and Public Petitions Committee in 2025. Our first item of business today is a decision on whether to take agenda items 4 and 5 in private, which relate to a consideration of evidence we are about to hear and our work programme. Are members content? Thank you. The next item on our agenda today is a consideration of the continued petitions, the first of which is petition PE 2048, Review the Fast Stroke Awareness Campaign, lodged by James Anthony Bundy, who is joining us in the public gallery this morning. Petition calls on the Scottish Government to urge the Scottish Parliament to urge the Scottish Government to increase awareness of the symptoms of a stroke by reviewing its promotion of a fast stroke campaign and ensuring that the awareness campaign include all the symptoms of a potential stroke. We last considered this petition at our meeting on 9th of October 2024, where in addition to seeking written evidence from NHS regional health boards, we agreed to hold a roundtable discussion on the issue raised by the petition. And I'm delighted to say we have two panels with us this morning to explore these issues. Our first panel, we have Sophie Bridger, Policy and Campaign Manager, Chest, Heart and Stroke Scotland, Michael Dixon, Chief Executive of the Scottish Ambulance Service, Professor Azad Majid, Professor of Cerebrovascular Neurology at University of Sheffield, and John Watson, Associate Director of Scottish Stroke Association. A warm welcome to you all. With the exception of Professor Majid, who's joining us remotely, our first set of panellists have previously had an opportunity to provide written evidence to the committee, so if participants are content to do so, we will move straight to discussions which we will broadly focus on the public awareness stroke campaign. Can I say good morning to you all? Thank you for being here. How would you less common stroke symptoms be incorporated in a public awareness campaign?
Do you need a volunteer to speak first?
Yeah, okay.
I think this is a contentious issue, so I'm sure that all of us who will give evidence to you today will be of a mind that the current situation is not good enough. We do need to see change. This petition has come about because of a failure in the system, and these kind of failures happen too often for stroke patients. We do have concerns about the idea of bringing the less common stroke symptoms into public awareness campaigns. And I would want from the beginning to make the distinction between the messaging that we give out publicly, which is primarily the FAST campaign, and the information and the training and education that goes to stroke professionals. So our concern over the idea of changing the FAST campaign is, first of all, that you have a campaign that works very well. It's simple, it's memorable, but it's also very focused on the specific symptoms of stroke. So you capture most strokes, but you get very few false alarms. And it works very well as a triaging tool, but it is not the be-all and end-all. It needs to be backed up by other opportunities for professionals to take more nuanced consideration. The concern with extending that out to wider symptoms is that not only are many of these very vague, and they relate to other conditions rather more than stroke, but also you decrease the propensity of people to remember what those are. And I know that you'll hear later on from researchers, and I think there is now good research evidence that says there's a real risk to people's retention of the messaging the more that you actually increase the amount of information that you're giving them.
Ms. Bridger?
If I may come in there just to echo what my colleague has said. We know that awareness of stroke symptoms in general is not as high as we would like it to be. So Chest, Heart and Stroke Scotland currently coordinates a national FAST campaign. And before we started that campaign, we did some polling to ascertain actually what the general awareness was of FAST as an acronym and stroke symptoms. And we found that only just over 60%, 62% of the public had an awareness of FAST. That is much lower than we would like it to be. Now, after the initial wave of that campaign, we were able to raise that to 68%, which we're very pleased with and we hope to build on in the coming years. But actually, I think it demonstrates just how low public awareness is generally, not just of stroke symptoms, FAST or BFAST, but actually the need for urgent action as well. And that is one of the things that we know that often, unfortunately, that is one of the last messages to get through. Stroke is always a medical emergency, and too often we hear that people do delay taking action, and the awareness of that need for very swift action, unfortunately, still is not high enough. We know that, again, as my colleague has alluded to, the best health campaigns are built on something that will be very familiar, I'm sure, to all the members here, the repetition of short, simple messaging over time. We are not advanced enough in that awareness yet. We need to keep repeating that message to build the awareness of key stroke symptoms and the urgency of acting very swiftly.
Mr Dixon.
I will support my colleagues entirely. We think the progress that's been made in FAST is really welcome. But we still see, from an ambulance service perspective, patients speaking to us and often delaying contacting us because they're waiting for all of the symptoms to be present rather than just one or more of the significant ones. And again, that's been backed up by the research that's been carried about of the acceptance of FAST as a process. There is a concern, of course, that if you add additional elements into that, that could further delay any patients coming forward and seeking urgent support and attention from Scottish Ambulance Service.
Professor Majid.
Yes, thank you. There's research that's been published very recently now from the United States, and we actually found a similar issue here in Sheffield that has actually shown that if you complicate the message a little bit more, just by adding the two letters, B-E, to FAST, that the retention of what those letters mean at 30 days is actually decreased. So I think if we want to get the message out to the public and improve that message and improve retention and improve action, then keeping that message as simple as possible is really the way to go. We considered going to BFAST here in England, and I've spoken to a number of my colleagues, NHS England and BASP, the British and Irish Association of Stroke Physicians, considered this, and we decided not to move forward with this, partly because of the concern with retention of the message and the action that needs to be taken, but also we felt that this would increase the number of mimics coming through. And I know that's not what we're talking about at the moment, but that is a potential consideration as well. So we decided not to move to BFAST because of the concerns that I've just raised and the concerns that my colleagues have highlighted.
Can I just ask, if we have this public awareness campaign and put symptoms into it, can you really highlight the risks that you feel there would be?
Is that a question for me? Or?
Professor Majid, I'll let you go first.
Mm-hmm. Yes. Well, I've just highlighted. Well, people have looked at this. People have looked at this in the United States, and in the United States, people want more people to come to hospital because they make more money. The hospitals make more money. So they looked at this, and they found that if you take two groups and you educate one group on FAST and another group on BFAST, that the retention of that message is decreased in the BFAST group compared to the FAST group. So I think there's research to support that. There's actually two studies that have shown that just by adding those two letters, you're complicating the message.
Mr. Bridges?
Yes, I think Professor Majid touched on the subject of mimics, and I will leave more qualified clinical colleagues to speak to the nature of stroke mimics. But I think there is a concern that actually by widening the net, as it were, we do not necessarily catch more people with atypical stroke symptoms. We actually make them harder to find because of the large number of people who could present with symptoms from, for example, labyrinthitis, migraine, seizures. So rather than having more people who can present at A&E with a posterior stroke, we have a much bigger number of people who then need to be triaged as well, and we make it harder to find those people. I know that Professor Majid has already touched on actually the context here. In America, where a lot of this research is being done, there's obviously a very different healthcare system to the one we have here. We know that despite the very best efforts of stroke clinicians who work exceptionally hard, the stroke healthcare is really struggling right now. Only 50%, just over 50% of those people who had a stroke last year received the stroke bundle. So that's the package of treatment that we would expect to see for someone admitted with a stroke, only half. The national target is 80%. So we are already well below where we need to be in terms of stroke healthcare in Scotland right now. If we widen the net, we reduce the chance, we risk reducing the probability that someone could get that healthcare in time.
Witnesses?
So I'd recognise from a clinical point of view, for us in the ambulance service, FAST is an initial trigger. It's about where we start our processes for triage and assessment, and that's from the initial call onwards. There is a risk, of course, if you widen that opportunity for people to come forward to raise symptoms which may be another cause. Either they get missed, which is not what we want to see, or alternatively, it means that those numbers of medical emergencies, and we do see a stroke as a medical emergency, start to get diluted till we're taking more patients through to accident emergency within an appropriate presentation based on that widened specification.
Thank you. Mr. Watson.
Very briefly hammer home that point, I think. So Professor Majid referred to some recent research, and when we submitted our written evidence to the committee, we said at the time that there wasn't clear evidence either way comparing FAST and BFAST. There have been 2 new studies that have been published since then, and I was looking at these yesterday, and just to give you the sort of one-line conclusions from each of those, because I think they're really very clear. One study said significantly higher retention and ability to recall stroke symptoms fully or partially was found with FAST. Adding B and E to FAST resulted in lower retention of more common symptoms. And then the second one, FAST outperformed BFAST in the ability for people to remember key stroke warning signs, suggesting the additional letters of B and E hinder memory recall. So the concerns that we have about diluting the message are real, they're very well founded, and I think the research backs them up.
Thank you for that. Maurice Golden. Oh. Professor Majid.
Yes, I think we all agree that we need something better. It's good, FAST is good, but there are opportunities to do better. One thing that we've been researching and looking at in England is that of video triage. So when the ambulance service arrive at the patient's house, we can video triage. We can see these patients on our screens by camera. The video is sent to us, and we can assess the patient. And we found the research has to be published yet and assessed properly, but we found that helped to distinguish stroke from non-strokes and reduce the burden on the stroke services. So I think, I know we're talking about something slightly different. We're not talking about a patient education campaign, but if we want to identify more stroke patients, reduce non-stroke patients coming in and overwhelming an already stretched service, then we're going to have to think about novel approaches that allows specialists to identify stroke patients that need to get to a centre very, very quickly. As we all know, time is brain.
Maurice Golden.
Thank you, Convener. Perhaps start with Professor Majid, just on your previous point. Are you aware of any work of utilising artificial intelligence in terms of being able to triage potential stroke victims?
Yeah. So this has huge potential. So what we've been looking at here in Sheffield, this is research now, that now with Vision AI, so Tesla's using this for self-driving. So using vision AI, it may be possible to actually identify stroke patients. So patients may be able to do that from their camera, for example. And but this is research at the moment, and I think that this will take time. This is too early at the moment. I'm aware of this because I reviewed the grant application. Is that there's actually work going on for a blood test that could be combined with FAST, so that to identify patients with large vessel occlusions. These are patients that are potential candidates for thrombectomy to be identified. So I think there's opportunity, but it's not here yet. AI and blood tests are not here yet.
Thanks for that answer. And Professor Majid, I'm also interested in BFAST as a stroke screening tool. And what is your view of the current evidence surrounding BFAST and other stroke screening tools, and how could that evidence base improve?
So I think FAST and BFAST, in my opinion, my reading of the literature, and other colleagues may disagree with me on this, is I think they're very similar in picking up stroke. So they have a similar sensitivity. They have a similar level of identifying, false positives as well. What we talk about specificity. So I think they're very, very similar. I'm not completely convinced, and this is my opinion, and as I say, other colleagues may disagree with me. I don't think that BFAST adds a great deal and risks the potential of increasing the number of mimics that come into the stroke service. But I'd appreciate the views of other colleagues to see what they think.
Thank you for that answer. I'd just like to bring the panel in the room just regarding the current evidence base around BFAST. Who would? Sophie?
I can touch on that briefly. And what I'd like to do is kind of summarise the position of what I've read in the clinical stroke guideline, actually, which was reviewed in only 2023, so about 18 months ago. And this is across Great Britain, Northern Ireland, and the Republic as well. And the working party that pulled together the clinical guideline for all stroke clinicians across all of those countries reviewed the evidence very well and very comprehensively, and therefore I'm also inclined to trust their assessment of this. And they found that there was not enough evidence to deviate from FAST for any other stroke screening tool. And I want to say screening tool as opposed to awareness campaign, because those are two slightly different things that we're looking at. There was just simply not enough evidence. That was also backed up by the most recent Cochrane review, which also looked at the stroke awareness screening tools. FAST is the only one that's mentioned in the clinical guideline because it is used very consistently and has a very good evidence base. And I don't think until that changes, there would be no reason for any of us to change and to use a different screening tool. There is simply not the evidence at this point. That's not to say that there aren't individual papers. There are always going to be individual papers that will find a particular benefit to a particular screening tool. But when we look at the body of evidence as a whole, I don't think it justifies, in my personal opinion, a move away from FAST.
Michael?
So Scottish Ambulance Service is first and foremost clinically led. So as and when clinical research changes and the evidence for how we change our practice, we change accordingly. Currently, our view backs that position that the evidence isn't there to make that change. Should that evidence come forward or a new tool prove to be more effective, then we, of course, would adopt it.
Okay, thanks.
And so I've nothing further to add in terms of the evidence. I'm in agreement with my colleagues on that. I would like to pick up on what Professor Majid said about other areas of research. So we're all, I think, of a mind that the status quo is not okay. We do need to do this better. We do need to have further research. And the question is, where do we put that research investment? Because one of the key criteria you need to know about stroke is that there is very little money spent on stroke research. We need to be very careful with where we spend that money. So, for example, the GHOST study that Professor Majid referred to, which is about either a blood or a saliva test that looks for the protein evidence in the bloodstream that indicates there's been major damage to the brain. That has fantastic potential to be a way of getting around the lack of visible symptoms and actually identify what's going on inside the brain. And that work is underway. So there is research that we can do that can help us to bypass a lot of the problems we have with identifying particularly posterior strokes that don't give obvious symptoms. I think we need to focus our energies and more money on those areas of research.
Thank you. Back to you.
Mr Ewan.
Thank you, Convener, and good morning to all the witnesses. I'm sure that you'll be well aware that this petition arose because of the tragic loss of life of Tony Bundy, and the petitioner stated that when Tony suffered a stroke, his face and arms were unaffected, his speech was not slurred, and that meant that he passed the FAST test because face, arms, speech and time weren't affected. The petitioners go on to say that they're now raising awareness of the symptoms of stroke, including the inability to stand, so balance, cold sweats, eyes struggling to focus. So that, I think, is where the B and the E come from, balance and eyes. Now, I mean, the evidence that you've all given is consistent with each other, that you don't think from the available studies and the evidence that the alteration of the awareness campaign from using FAST to be FAST would work. But I think Mr Watson began by stating that there is a problem. So, you know, putting it in sort of layperson's terms, there is a problem. The current system is not identifying all of those who may have suffered a stroke, but you think that FAST is the best there is, and if we're to depart from that, then it might make things worse, not better. And that's just putting it in sort of layman's terms. And I mean, I can understand that, and I'm not a clinician, so it's not for me to second-guess anybody. But the committee did write to all the health boards in Scotland, and one of the responses was from NHS, Ayrshire and Arran. And in their written submission, they say, the team at NHS, Ayrshire and Arran, and they describe the work they've already done, which is quite substantial and quite impressive, I think. But I won't read that out because it would take too long. They would very much welcome the opportunity to be a pilot site if this was agreed. Now, my kind of point to you, I just want to try this out and see what you say, is studies are one thing, but would it not be better, given that there is a health board willing to carry out a pilot, and given that the Minister has said in her response, the Minister for Public Health, Jenny Minto, has said that it's up to health boards to do this. So she's not standing in the way of a pilot, as I understand it. I'm not sure that she's advocating it. But would it not be sensible to actually try it out? And is there a risk, and I don't mean to be impersonal in any way, that your evidence and your knowledge is obviously, it comes from your experience as professionals and clinicians. But, you know, a layperson might say, well, for goodness sake, give it a try. I mean, studies are one thing, and as has been pointed out, studies from the USA may be of limited efficacy because of different circumstances and the profit element. But surely it would make sense, would it not, to have a pilot scheme? And if that were conducted under scrupulously pre-arranged terms, then it might be possible to measure the outcome and see if that actually works. And I know that this idea was promoted by Mr Kerr and Mr Stewart, two other MSPs that have been supportive of the family in this case. I'd like to ask all of the witnesses if they think that might be worth trying.
So, obviously, if health boards would like to pilot a different stroke awareness test, that is entirely their prerogative. I think we would stress that obviously it would be extremely important to do that in partnership with Scottish Ambulance and, of course, with their emergency departments being very involved in that as well. We are aware of previous pilots that took place in another health board. though I note that they've not mentioned this in their written evidence, so it may be that they no longer hold records on that, which did unfortunately lend itself to the false positives that we are aware of. The other thing that I would like to stress is, I think up until now we've not really talked about the importance of professional education, which I think gives the opportunity to make sure that we are picking up on posterior strokes and atypical symptoms across the whole of Scotland, where, and again, to build on John's point, we don't accept that the status quo is good enough. We do clearly need to do more to pick up on posterior strokes, but that professional education has a significant role to play in that. So at the moment, Chest, Heart and Stroke Scotland has just begun a new programme for this coming year on stroke education, where we hope to reach 1,000 healthcare professionals this year. So far, we've had 950 sign up. And in that training, we talk about stroke awareness. We do talk about FAST, as is mentioned as the crux of kind of clinical guidelines. And we also talk about atypical symptoms. We talk about the importance of listening to carers and families, and that someone can be FAST negative and still have a stroke. There are limitations to FAST. Stroke is complex, incredibly complex, and FAST is not perfect, but what it does do is an incredible job of distilling a very complex event into something that can be recognised by members of the public. It's very challenging, and I have a lot of sympathy for colleagues who are working around the clock to detect and treat as many strokes as possible, including those of my colleagues at the ambulance service who are doing so much of the triage. And if there's more that we can give them to upskill them, to increase their confidence in making sure that they, as the people who are often at the front line, are able to detect those strokes, even with atypical symptoms, and recognise them, that is where I feel we would see the most benefit from investing our energy.
Which health board were you referring to?
That would be NHS 5.
Sorry?
5.
5. Okay, thank you.
So we're aware of the NHS 5 pilot as well. I think that the fact is that we're looking at this as a kind of an either-or situation, and as Professor Majid referenced, the use of video technology to be able to better assess patients who are contacting the Scottish Ambulance Service or NHS 24 because something isn't right, something is different, and that's often the reason why people call us. And again, whether that's based on FAST or whether that's based on balance or eyesight changing, these are all really reasonable justifications for contacting NHS24 or the ambulance service. So that use of video technology could be more powerful and more effective in helping us further triage, stratify why something isn't quite right. And again, to back at that point entirely, the education, the wider education for staff of understanding what this could be, the atypical symptoms as well as the typical symptoms, can be more powerful than just necessarily revisiting a pilot that has already concluded and the wealth of evidence that currently rests around the FAST as a tool, initially as a triage and an assessment tool.
So, in terms of pilots by health boards, for me it would come down to what it is that the health board would be looking to pilot. And we would have concerns about piloting public messaging in a particular area, which would have, if that was different, it would have the potential for confusing people. But if it was a pilot that was looking at how are the professionals within the health board briefed and prepared and able to give time to more detailed examination of potential stroke patients, that would be very welcome. And for us, certainly, FAST is one tool. It's a very effective tool. We think it should remain sort of the front line of stroke diagnosis. But it doesn't do everything. As the petitioners have pointed out, it does miss a lot of people. And for the system to work better, we need to also look at having the next step. For people who don't show obvious symptoms, who are showing vague symptoms, there is no substitute for having time with a professional who knows what they're doing, who can try and figure out what's going on. From the symptoms that somebody is showing, they might have an ear infection, they might be dehydrated, they might be having a stroke. That takes time and expertise to work through. And one of the ways that our system is failing at the moment is that the emergency departments that people arrive at are overloaded. I think we probably all saw the Royal College of Nursing report a few weeks ago that talked about corridor care now being the norm. And we need to have a backup to FAST that is the situation whereby professionals can help people. And that requires the information and the guidance that Sophie's referred to. It also requires people having the time to actually spend with patients to figure out what's going on when there isn't an easy way of doing so. So I know that all of us working in stroke are very conscious that the figures and performance in stroke at the moment are absolutely not good enough, despite the excellent efforts by stroke teams. Partly that's about the resourcing of stroke itself, but partly that's because the effective treatment of stroke patients relies on people getting to the stroke team quickly and efficiently. And at the moment, emergency departments are an absolute bottleneck for that. So it's going out with the remit of this committee, and it's not a stroke issue per se, but actually one of the big factors that's affecting this issue is the fact that emergency departments are so overwhelmed that they cannot give the time and attention that people presenting with vague symptoms need in order to actually identify what it is that's going on.
Thank you. Professor Majid?
Thank you. I think there's 2 points I want to make, and my colleagues have very eloquently made a lot of important points. I think the way I look at this, I think the priority should be to get the right patient in the right place as quickly as possible. The right patient in the right place as quickly as possible. And EFAST, I don't think it's going to take us there. I think these other things that we've talked about, video technology, blood tests, artificial intelligence, not there just yet, but certainly video technology is moving very fast, and we're using it a lot here and in other parts of the world. And we'll see that it's adopted much more frequently in the future. But I just want to add something to what was said about the services already. Now, the situation which is distressing to me as a consumer of the service as well recently with a family member who had a stroke, is that if you have a posterior circulation stroke, which potentially could be a devastating stroke, but if you arrive in the hospital, say you're correctly identified, you get to the hospital at 6 o'clock in the evening, right? And you would be eligible for life-saving or life-altering therapy, then you're too late, because in a lot of places you won't get that treatment after 5 o'clock. So this is, at the moment, the stroke services are so stretched. We're not even able to provide life-saving and life-altering treatment, which patients who get to hospital quickly enough are eligible for. So my humble suggestion here is that our focus should be on looking at technologies or processes that allow us to identify patients, the right patients, and so that they could go to the right place. And I'm not sure BFAST is where we should be putting a lot of our resources. Perhaps video technology, which is currently being piloted around England and in other places, may be where our priority should be. Just an opinion.
Well, thank you all for your responses, and I can understand that this is a very complex, multifaceted issue. The role for education is vital. A&E facilities not being available after 5 o'clock is an obvious and very serious failing and gap in services where that occurs. So I don't gainsay any of that, accept all of that. The petition we have here is concerned about one aspect and one aspect alone, although I'm sure the petitioners would welcome a very much improved service in all these respects. But I just go back to the point that given that what's at stake here is potentially life-threatening condition, and one where the petitioner's family lost their son, does that not really kind of, in terms of determining whether or not just a pilot should be carried out, does that not tend to push the balance into having a proper test conducted, as Mr. Watson has said, with a set of pre-arranged fixed criteria governing both the role of the ambulance service and the consultants and other clinicians involved. I mean, surely if there is a willing health board, then it might be beneficial. If, as the consistent evidence we've heard from all four of you is that it doesn't work, it doesn't work. But there does seem to be a very strong presumption here that people aren't quite smart enough to be able to take in complex matters, and that could be interpreted as well, being somewhat dismissive or in stronger terms than that, frankly, because we are dealing with a life-threatening condition here, and some people, as Mr. Watson said in his opening answer, lose their life as a result of not being amongst the FAST criteria. Would that not be worth trying? And if it doesn't work, then you've tried it and you've got a better cohort and evidence base from which to proceed and focus largely on all these other issues which you've very fairly and reasonably brought to our attention.
Can I come to Sophie first?
Apologies to Michael for cutting in. I think we would all agree that, as John has said, that the status quo isn't good enough. We are all acutely aware that this petition has come about through a tragic loss of life, and I'll personally like to give my recognition to the Bundys for what they've done in terms of raising awareness of posterior stroke with decision makers and with clinicians as well, which has given us all a chance to go, how are we making sure that we're getting this right? In essence, I think we all agree on the problem. We just don't believe that this is the right solution. Again, as I've said before, if a health board wants to pilot this, that is entirely their prerogative. But my concern would be that instead of making it easier for posterior stroke patients and patients with atypical symptoms to get to the right place at the right time, to use Professor Majid's expression, that we lose them in the noise, that we have too many people with mimics, as we call them, stroke mimics, that makes it harder to find those people and get them to the right place at the right time. The significant adverse event report, which I know has been published by NHS GGC, said that they concluded that they did not feel that BFAST was suitable for a universal application, and they based this on their conclusion that up to 1 in 6 or 1 in 7 of all patients could have some of the BFAST symptoms at some point. So that is an idea of the scale that we're talking about. We all very much want to make sure that patients with any kind of stroke are getting the right treatment at the right time, but we are also very concerned about the possibility of creating so many false positives that we cannot find those people and get to them in time.
Michael?
Thank you. So I think that's a really fair reflection. I think that we work routinely with health boards on innovative projects, different ways of working, recognising the unique nature that is health and social care across Scotland. So undertaking a pilot which has got well-bounded scope, a good grounding in evidence, and deciding whether that's going to make an impact. But the core principle of all of those studies references on the principle that you don't seek to cause anyone further harm, and the risks that we're talking about of the wrong patients being identified and potentially reducing that limited capacity for stroke teams to be able to see, because there are a number of mimics that are coming forward, again, is a real consideration that we would need to take forward. I think the other part of that is that any study that would need to be considered would have to consider the other factors as well. Are there other alternative methods, and we've been exploring video technology in Scottish Ambulance Service, that could make a greater difference? Because at the end of the day, what we're all talking about is better outcomes for patients who've been diagnosed with stroke. So recognising the tragic loss for the petitioner, and again, extend my personal condolences, but there are other methods that we should explore, and the evidence is pointing over and above the BFAST method.
Witnesses have any comments?
Perhaps some of the same comments, but just to to wrap them up in how the Stroke Association sees this, we are very conscious of how much needs to change in stroke care in Scotland. And we're very conscious of how little in the way of resourcing there is available at the moment. So while I appreciate we could approach things saying, well, let's go and find out, any knowledge will be useful to us, let's test things. We have so many things in front of us that we could test, that we could research, that we could try. We have to triage those things themselves by the things that appear best placed to actually be able to help us and to have the least likely negative impact. One concern we do have about a widespread BFAST message is you flag up, as Sophie has said, a very large number of people as potential stroke patients. And what do you do with those people? We already have a stroke service, stroke physicians, scanners, stroke beds. All of these are already under huge pressure just from dealing with the numbers that they have. If you're dealing with a lot more priority calls going to the ambulance service, every one of those results in somebody else being deprioritised. So there's real potential for harm by doing it, and it does not feel to us as if there is the evidence or the indications that the likely benefits would justify that.
Maurice Goulden.
Thank you, Convener. I mean, I think the nub of this is that James Bundy's father received video technology from the Scottish Ambulance Service that ruled out a stroke and an ambulance wasn't dispatched. And I think from the evidence we've heard, a lot of it appears to be around capacity and therefore prioritising some patients or others. Ultimately, the NHS is free at the point of delivery, and I think capacity management, in my view, shouldn't really come into an evidence-based approach over triaging people. And yes, there might be people who present falsely, but that is a matter for the Scottish Government to provide that capacity and allow people to access the treatment. And I just wonder if the panel might step back, and if there was capacity in the system, what would your reflections on BFAST be? The same?
To that, we continually come up against the reality of lack of resourcing in stroke, but leaving that aside for the moment, for me the key issue is that if somebody is suddenly and very unwell, they should be contacting medical services. We should have medical services who are well briefed about the obvious symptoms of stroke and about the fact that people who present with general symptoms, it could be one of a number of things. And we then need to have the pathways so that people get to see somebody who is best placed to try and determine what is going on. My concern about having BFAST as a general rule is that you automatically flag a very large number of people as potential strokes and you send them off to the stroke department. I think the right place to deal with people where we don't know what's going on and they're showing very general symptoms is in the emergency department to be seen by generalists. And the problem is that you would simply transfer a lot of difficult to diagnose patients from the emergency department, which is there to deal with them, into the stroke department, which is not there and not well placed to deal with them. And most of them would then be sent back because most of them wouldn't be having strokes. That would be an inefficient way to treat people, even if you weren't worried about resources. It's about getting people to the right place at the right time as quickly as possible. And the emergency department is where people should be going to if it's not clear what's happening with them. Underneath all of this is just the unavoidable and unfortunate fact that for some strokes, they do not give very obvious physical symptoms as to what's going on. They're very hard to diagnose. And in preparation for this discussion, I've been to speak to various stroke clinicians, and I hear the same thing back all the time. It's just really hard to identify what's going on. And I know we as a panel keep jumping onto other issues. It's because there are other ways that we can hopefully get around things like that, like the blood tests, like having the video triaging to improve your chances, even if it doesn't, guarantee you'll get a good result. So that for us is the key thing. It's getting those things lined up.
Thank you. Back to you, Convener.
Other witnesses have any comments? No. Mr. Chowdhury.
Thank you, Convener. Good morning, panel. Before I go to the last question, I guess I'll be asking, Sophie, if said training, does that only happen in NHS 5 or is happening in other?
So the training that we offer is available it's online. So we are making this accessible, obviously, to any healthcare professional in Scotland who wants to join. For the first session of this year, which happened last week, we had 250 people join us from across the country, and that included from primary care, from Scottish Ambulance Service, from the emergency department, and others as well.
Resources. You talked about resources and getting to the patients. I mean, do you have any data where if a patient has made a call, how quickly the ambulance services or the patient has been seen and what happens in between?
So we recognise stroke as a key priority, so it's one of our most urgent responses. The routine is that we will pre-alert the hospital to say that there is a stroke patient coming in, so the teams can prep for the patients. So again, this is all a well-rehearsed triage process, acknowledging the points that have been discussed previously about the challenges that exist about certain strokes being identified. We measure those times clearly, and we can provide, because all of our patient interactions are coded, we can provide some more evidence to the committee if it would be useful about the specific times and our turnaround for those. There are factors that do affect those, and I don't think we necessarily want to go into that scope of hospital turnaround times, etc. But we do prioritise our most urgent, and stroke is considered as part of that.
I guess you won't have any data that how many stroke patients had to wait and how long they have to wait in between from the call to the ambulance services arriving to their...
I'm happy to go away and provide that information to the committee if that would be useful.
So how could awareness of these symptoms be improved? And I guess that will be the question for all of you in the panel.
So I think colleagues have spoken about it. You know, the awareness has been improved. You know, the public health campaigns are really welcome. We would always encourage patients to come forward if they're presenting with not waiting for all of the symptoms to line up before contacting Scottish Ambulance Service, but acknowledging it's a continued messaging process to the public to make sure it's reinforced about the impact and the urgency about this.
Sophie, do you want to...
In terms of, sorry, could you repeat the question?
How could awareness of these symptoms be improved?
So I think in terms of increasing awareness with clinical audiences, and again, Scottish Ambulance Service and healthcare professionals, I think we're getting quite a good way actually with the training that we're providing. As I say, we hope to reach 1,000 people this year, and the vast majority of them have already signed up to a session. So we know that this is something that healthcare professionals want to know more about, and actually providing that information to them about actually what FAST does and doesn't do, and how to act accordingly, basically, for someone that they suspect is having a stroke, even if they're FAST negative. That's information and education that we know that healthcare professionals really want.
I think to reiterate the earlier point, but there needs to be a twin track approach. So there is a definite need for education and training and guidance for clinical practitioners, for those who will working in the medical profession who will see patients. Alongside that, we do need to see public awareness campaigning, and I hope we haven't given the wrong impression by questioning the idea of BFAST, but we have not had a FAST awareness raising campaign funded by the government for some years in Scotland. All the other constituent parts of the UK have done that. The Stroke Association was part of a working group with NHS England that was reviewing FAST campaigns, and what struck me from the reports I saw from that was how quickly public recognition and awareness fades over time. And the recommendation is certainly to have a properly funded, very visible awareness raising campaign every couple of years. And it's been quite a few years since we've had that in Scotland. And if our public is anything like the public elsewhere in the UK, we will be seeing an ongoing decline in awareness because of that. So there's no getting away from the fact you need to spend some money on this. But at a time where money is tight, I would point to the fact that in the NHS England evaluation, they found a return on investment of 8 or 9 to 1. So every pound spent on fast awareness-raising campaigning resulted in savings down the line, economic savings of 8 to 9 pounds because of reduced treatment, earlier treatment, better treatment, and that's over and above the benefit to patients themselves.
Arshad Majid, have you anything to add?
No, I think I think my colleagues have made all the points that I would want to make. I think just going back to the question that was asked earlier, if resources weren't a problem. Well, I mean, I understand the question, but the problem is that the reality is that resources are a problem. And the point that John made earlier on, that look, if somebody comes in who's not having a stroke, then, you know, they're potentially using a resource, for example, a CT scan or whatever the test may be, that's been denied to a stroke patient in a timely manner. So that was the only point I would make. I think my colleagues have made the other points I wanted to make.
Thank you very much. Thank you, Convener.
Thank you. One final question for Mr Dixon and Professor Majid. How are less common stroke symptoms currently considered when assessing patients for potential strokes? Who would like to go first? Mr Dixon?
Right.
So we have a very detailed triage process when patients contact 999. The first two questions are the patient breathing, is the patient conscious, and that triggers a response from there. We often work through with the patient at some level of detail, depending on the symptoms that's presented, a range of options that could be appropriate for them using either our integrated clinical hub or our teams that are embedded. But from an ambulance response point of view, if we feel that the patient warrants an ambulance, we will send an ambulance. It may take some time to get there. Or alternatively, if we think that that patient's presentation requires an alternative treatment that could be achieved in a different way, such as either directly attending accident emergency or going to their GP accessing primary care, we will advise that accordingly. So it's a really robust set of triages, but no system is perfect, and we acknowledge that. And we're always looking for improvements we can make based on learning when things haven't gone as we've intended to, and we understand the impacts on individual patients when that does occur.
Professor Majid?
Well, I think it'd be useful to the committee to hear what happens in Sheffield. So when the ambulance service arrives in a patient's house, if it's very clear they're having a stroke, they alert us and they bring the patient in. If they're not certain, for example, if they think that the patient's having a stroke, but they're unsure about whether they're fast positive or not, then they set up a video call with us, and we have a stroke nurse specialist who helps us to evaluate the patient. If they're unsure, they can ask another colleague to come and evaluate the patient. So that is one way we can pick up patients who present with the less common symptoms of stroke or atypical symptoms of stroke. Yes, will we miss patients? Yes, that will happen. No test is 100%. But I think this works very, very well here, and it's a model for the future.
Thank you. Before we draw this session to a close, is there anything that the witnesses would like to add that we haven't covered?
I'd just like to speak to one of the points that the petitioner made in the most recent submission, which is actually not about FAST or BFAST, but around stroke care in general, and specifically the issue of thrombectomy. So this has been an issue of great concern to stroke clinicians in Scotland, to ourselves at Chest Heart and Stroke Scotland, and I know to the Stroke Association as well for a considerable period of time. Thrombectomy is a life-changing treatment for stroke. and at the moment it is not available outside of working hours. There is only one place in Scotland where this is available at the weekend. So there is a significant issue around the time availability of game-changing stroke treatment, which should be available to every stroke patient. So I would like to again say that that is a particularly important issue that the petitioner has raised in the most recent correspondence, and one that I suspect is supported by many of us within the stroke community.
Any other contributions? No. If that's the case, can I say thank you very much for your evidence today, and can I suspend the meeting briefly so we change panels? Welcome back to a meeting of a Citizens Participation and Public Petitions Committee. We continue our roundtable discussions on Petition 2048, Review the Fast Stroke Awareness Campaign, and have been joined by Dr Ron Cook, Medical Director of NHS 24, Professor Mary Jane MacLeod, Clinical Pharmacologist of University of Aberdeen, and Professor William Whitley, Centre for Clinical Brain Sciences, University of Edinburgh. And can I welcome you all? Following on from the discussions of a public awareness of stroke symptoms, the committee would like to explore some of the more issues around clinical awareness symptoms. So we'll just go straight to questions if you have nothing to say. And can I lead off? And how are less common stroke symptoms currently considered when assessing patients for potential strokes?
Possibly not very well, but usually we're seeing them in the emergency department, so we'll be called to see patients where any emergency doctor thinks a patient may have a stroke. And probably 3/4 of the time, the patients we see haven't had a stroke. To put that, can I talk about it in the ED setting? Is that okay? So about 3% of patients who come to the emergency department will have dizziness as a symptom. And of those, less than 5% will have a stroke. So there are a lot of patients to sift through to pick up the stroke. So the importance is a very clear history and a very clear examination, and a very thorough examination using validated tools to try and differentiate stroke from other causes of dizziness or vertigo. So it's mostly a clinical diagnosis, and there's pretty good evidence that a clinical diagnosis is better than imaging for identifying these patients. But it's still difficult. There are a proportion of patients who might just have isolated vertigo, which looks like a peripheral cause, but they have a stroke, and that can be very hard to diagnose.
So, Yeah, so let's think about people with severe symptoms and people with mild symptoms. Posterior circulation strokes, as we've heard already, are a range of symptoms that many people experience not related to stroke. So if those symptoms are severe and they've come to the emergency department, they're usually assessed either in triage or they're assessed after admission by an emergency department doctor or nurse who needs to raise the suspicion of stroke to get the assessment of someone like me or Professor MacLeod. So that suspicion raising is the important thing with people's severe symptoms. In people with mild symptoms, and we should remember that mild symptoms are extremely common and are a major major source of work for the stroke service, a GP usually refers either by telephone or directly to a stroke physician, and then we see them in outpatient clinics where the majority of the patients we see have not had either a mini stroke or stroke.
From my experience in emergency medicine and with NHS 24, I'd agree with both of those statements. I think key to this point is that tools like FAST should not be used as an exclusion criteria. FAST is an inclusion criteria, and that is really important when it's considered in its use in public messaging, that it's there to identify very quickly those people who are obviously having a stroke so they can be availed of life-saving, life-changing treatment. And the key there is the T. Call emergency services now. Now, the effects of that, if you included dizziness or balance, where a vast majority of people calling their GP, calling NHS 24 or turning up to an emergency department do not have stroke, or eyes, where most blurring of vision results from some sort of a local eye condition, then that, in line with previous evidence, completely dilutes those folk who are having a stroke, and also affects an emergency department's ability to pick up the unusual symptoms of stroke in the unusual patients. So I think in terms of assessing more uncommon symptoms of stroke, the key at front doors, the key in emergency departments, GPs, is education and awareness of health professionals, and introducing systems to emergency departments that avails senior doctor review of these patients very early, so they can muster the appropriate response within the hospital.
Thank you. On that point, do you feel there's a current awareness of less common stroke symptoms amongst clinical staff?
Yeah, so of course there's a variation in awareness of stroke as well as of all conditions. But we have to remember that we're dealing with professionals, and continuing education of professionals, nurses, paramedics, and emergency department doctors is really important. I think if you spoke to any specialist, they would always say that there is under-awareness of their particular condition. Stroke is particularly important. And in my view, there is under-awareness, and we should continue our efforts. But that's probably the case for most conditions. If we had a cardiologist here, they would say the same.
Just to reiterate that and say, particularly with the more severe end of the spectrum in our emergency department, we had issues with basilar strokes being missed because the patient presents with a reduced conscious level and nobody thinks of stroke. So we had an awareness sessions with the emergency department, and it was over a year until there was another case. And again, with changing staff, junior staff in particular in these departments change every 4 to 6 months. You need to just keep continuing, like re-educating the public, you have to re-educate medical staff as well. So I think education is a huge part of this. So people, doctors and increasingly nurses are aware of these symptoms.
Could I just say one thing that was relevant to the point made earlier about thrombectomy, which is that as a very effective treatment becomes available, doctors are much more interested in identifying people who are suitable for that treatment. If you work in a place where that is not available, which is many places in Scotland, of course, thrombolysis is quite effective. It's simply not as effective as thrombectomy. If you give doctors an effective treatment or nurses an effective treatment they can give, they're going to be working very hard to identify those people. And as we've heard before, that's not available to many people, to most people in Scotland at the weekend or evenings or during the night.
Dr. Cook?
There are also far more detailed assessment tools available to health professionals in emergency departments to assess patients presenting with stroke, which include the details around problems with vision, problems with balance. The National Institute of Health stroke score is widely used to assess patients presenting for availability for thrombectomy and thrombolysis, and they are far more detailed, but obviously require the training to be able to elicit those physical signs. So I think in terms of the points around ongoing continuous professional education and development and reminders in how unusual strokes present, and even in terms of information and education that's available to the general public, NHS 24 governs NHS Inform, and whilst we lead our stroke pages with a fast message, immediately below there is also information around more unusual details of stroke. And I think that's where FAST is such a useful tool in that it's simple, it's short, it's punchy, but it can be used as a gateway to provide more detailed information about stroke.
Thank you. Just to let the witnesses know, the technical staff will operate the microphones. Maurice Golden.
Thank you, Convener. Panel, the petitioner mentions research from Australia, which has a similar healthcare system to us, which showed that BFAST was used in a live medical setting, and the result was quicker detection, quicker treatment and better outcomes. Focusing on FAST, what is your assessment on how many strokes FAST might miss? Are we talking about 1 in 5, 1 in 10, 1 in 20?
I've looked at this specifically. So FAST misses about 14% of all strokes. FAST misses about 40% of posterior circulation strokes in some studies. So it's not that specific for posterior circulation strokes. But again, just to bear in mind that there's a huge range of posterior circulation strokes from very, very severe to very, very mild.
Okay. Yes, Doctor.
I think the key in terms of application within a healthcare setting, the point I made earlier around being very clear to healthcare professionals, junior doctors, those clinicians triaging patients, is that FAST is inclusion, it's not exclusion. You don't say someone is FAST negative and then say they're not having a stroke. And that comes down to the education within your department, within your board, and the awareness of different stroke symptoms. So, and that's more nuanced amongst the practice of healthcare professionals. I'm sorry, I'm not aware of the study in Australia, but they, in terms of the references earlier to video consultation, I've certainly practiced in Australia where video consultation supports remote treatment of stroke, and that's obviously an area where those more nuanced and more detailed tools can be employed to aid a video consult remotely.
Thank you. Yep.
Yeah, so just on the Australia question, so in preparation I spoke with a colleague in Perth, and looking at the study I think we're referring to in Perth, that was a study over 2 years that identified 200 people with stroke in their hospital, remembering that hospitals in Glasgow and Edinburgh see between 1,000 and 1,500 strokes people per year. So we're talking about things at a very different scale. The second thing on how did these different scales perform, so if you look at in the real world, that's taking everybody come to an emergency department who has symptoms that might be suspicious of stroke, which is really what we're interested in. There are very few studies like that, but where those have been done, many of the scales perform very similarly, including my own study, which compared one other scale, not BFAST, with FAST. The key thing is not the scales, it's actually the training of the people doing it. The scale is there to increase awareness, make someone think about it. So if someone's got their thinking about stroke in someone with neurological symptoms, that's just as important.
Thank you, panel.
Mr. Ewan?
Just following up on Dr. Cook said in relation to making the distinction about FAST not being a measure to exclude people but to include people. I can understand the distinction, but surely, at least so far as the general public is concerned, because the two particular issues of balance and loss of fully functioning eyesight, balance and eyes, is not included in VAST, then as far as the public is concerned, it is exclusive, isn't it? Because we are giving out an information campaign, an awareness campaign, which doesn't include two of the factors, which in the case of the individual that tragically lost his life, appear to have been the symptoms which were detectable. Now, if I'm just playing the devil's advocate a little bit, but surely, as far as the general public is concerned, it is exclusive. It's not inclusive by definition.
So that's the application. Yeah, that's the detail of the training of the application of healthcare professionals, that it shouldn't be exclusive. So in terms of the problem with that is, so the face speech of the FAST, those are included in FAST because a majority of people who complain of those are having a stroke, and that's why it's so applicable to the T in phone emergency services now. A vast majority of people who complain of being dizzy or complain of having blurred vision are not having a stroke, a vast majority. And so if that was linked to the advice of call 999 now, then that would have a significant impact on the ability of ambulance service and emergency departments to respond to strokes.
Could I just ask one further question to Dr. Cook, if I may? Sorry, I don't mean to neglect the other witnesses, but the question relates to NHS 24. Sure. I mean, many people's experience of NHS 24 is that it's not quick. It can be extremely slow, and there's reasons for that, practical reasons for that. And very often someone is told that they will get a call back from a GP, for example, and that can take quite a long time. So, I mean, I'm just genuinely curious, I'm not really making a criticism, Dr. Cook, but what role does NHS 24 have really in relation to strokes? Given the risk of death very quickly, surely NHS 24 is really not the applicable service for strokes. And in the triaging that goes on in the first interview, you know, how do you take account of the BE in terms of your staff dealing with those cases?
So in terms of identifying life-threatening or life-changing strokes, we're very careful in providing information immediately when someone phones 24 in terms of the recorded message of the information they receive from the outset in terms of stroke symptoms. And if you think you're suffering from a stroke, you should hang up and phone 999 straight away.
Well, look, if I phone up and I say, look, my balance is affected, my eyesight is affected, what does the triage... I mean, you've got protocols and sort of matrices, I don't know what the right word is, that determine the response that NHS operatives give, and I'm not sure if they're all, to what extent they're all qualified, excuse my ignorance, Dr. Cook, but you know, if I say, well, you know, do you feel dizzy? No. Have you got slurred speech? No. But my balance is affected and my eyesight has suffered a bit. What would you do then?
Yeah, so the way that our decision support system's set up in terms of selecting keywords, then the most severe symptom is selected first for analysis, and then the most significant possibility of that keyword is then assessed by our clinical staff. So if it was visual blurring, then the first line in terms of differentiating that is this person having a stroke, or is it, if there's balance problems, then that would be at the top of our clinical assessment and excluded before we moved on to different things. So in terms of our clinical algorithms and our clinical training, then those more significant presentations look to be assessed and excluded first before we move on to others.
Well, that's interesting. I think algorithms was the word that I was unsuccessfully
hunting for. We use a limited number of algorithms. We rely a lot on direct clinical supervision from experienced staff. What we do use is clinical support to enable our initial call handlers to gain as much useful information from the patient as possible to make that clinical supervision more efficient and more effective.
Well, thank you for that, answer. It would be very helpful, Convener, if Dr. Cook might follow that up with some letters setting out the protocols just for our information, a sort of factual, evidential basis showing what the protocols say, because helpful. Thank you.
Chowdhury.
Thank you, Convener. Good morning, panel. From your clinical perspective, what are the risks and benefit of including less common stroke symptoms in clinical stroke assessment guidance?
So I just wanted to follow up quickly on the last point as well, which is relevant, which is that if you're looking at communicating messages of uncommon symptoms to the public, you need to make sure there's been a lot of effort already in FAST, and so there is at least some community awareness. And if we decided to change that with a more complicated and more difficult to remember algorithm or acronym, then that work would need to be done to check that people are happy to remember that. And there are also conflicting messages. So I was in the pharmacy yesterday, picked up a public health awareness campaign about migraine, which says seek help for migraine if you have nausea, vertigo, and visual symptoms. So there will be all sorts of conflicting things the more complicated you make it. So does that answer your question?
Can I just give you some data from the Scottish Stroke Care Audit for 2023? So there were 28,300 calls to the ambulance service that were coded as stroke by the call handlers. On the scene, the paramedics diagnosed 7,891 as potential hyperacute stroke. So that's less than a third of what the call handlers coded as potential stroke. And we know, certainly in Grampian, that potentially half of these actually turned out to be strokes. And hopefully for this year, we'll have all that data linked up in our national report. So one can imagine if you added BE into FAST, that these 28,000 calls could potentially go up to, I think it's fair to say, 33, 34, 35,000, with the knock-on effects on the ambulance service and then on the emergency department. So these are huge numbers. If about a quarter of strokes are posterior circulation strokes, that might be about 2,000 across Scotland. So going back to the question about Ayrshire and Arran doing a study, the actual number of posterior circulation strokes might be quite small within a health board region, so you might not have enough data to have a meaningful study. So it might not be possible to do just within one health board. So I've gone around a few subjects, but tied together.
Sorry, how less common symptoms included in clinical training was the question. Yeah, so I think it comes down to identifying how strokes very commonly present, and then squaring that away, and then have very directed focus. And posterior stroke, in terms of emergency department, has recently been an area of priority in increasing awareness, increasing early detection, so these patients can be availed of therapy, and that is again through departmental training, departmental process, making sure that their initial assessment either at triage or by, say, a junior doctor, and if they're FAST negative, that doesn't exclude them from being a stroke, and being aware of trigger points which involve senior staff to then muster specialist assessment.
Thank you. Thank you, Convener.
Dr. Cook, this one's specifically for you in NHS 24, and NHS 24 is a point of contact by most of the public. You're preparing a revised stroke education training package. Have you seen it, and does it cover the symptoms that we're talking about?
Certainly, in terms of our approach to stroke education, the symptoms of balance and eye changes are definitely included in stroke education packages, and we'd be very clear across all our education of clinical staff and ensuring our algorithms that if there are significant upsets around that which are in keeping with a potential stroke, then that was identified. Yeah.
Thank you. Do any of the witnesses have anything else to say that we haven't covered?
Yeah, just one thing to say. So I'm the clinical lead for the Scottish Stroke Research Network as well. The questions the committee are asking about the performance of BFAST for other scales or other ways of identifying stroke are research questions. There's a recent MRC committee, MRC report which came out just a week ago, where Anna Dominicek, the chief scientist, also contributed to really telling us about the decline in clinical researchers, the kind of people you need to do this, to answer the questions the committee is asking.
Thank you. Can I thank the witnesses for their contributions today? And if the committee are agreed, can we take the evidence we've heard and the written submissions at another meeting? Yep. Thank you, everyone. And can we suspend briefly? Sí. Our next petition is petition 1812, protect Scotland's remaining ancient, native and semi-native woodlands and woodland floors lodged by Audrey Baird and Fiona Barker on behalf of Help Trees, Help Us. The petition calls on the Scottish Parliament to urge the Scottish Government to deliver world-leading legislation giving Scotland's remaining fragments of ancient, native and semi-native woodlands and woodland floors full legal protection before COP26, UN Climate Change Conference of Parties in Glasgow in November 2021. We last considered this position at our meeting on the 17th of April 2024, where we agreed to write to the Cabinet Secretary for Rural Affairs, Land Reform and Islands and to the Confederation of Forest Industries. We have received a response from the Minister for Climate Action restating the Scottish Government's commitment to addressing biodiversity loss and noting that some of the action is already taken to deliver nature restoration in advance of Nature Environment Bill being brought to Parliament for consideration. Members will also have noted from our papers that since the Minister's response we have received, the Scottish Government has published a summary of the responses received in its consultation on the strategy framework for biodiversity, as well as its biodiversity delivery plan for 2024 to 2030, which indicates the new register of ancient woodlands is due for delivery by mid-2027. Members will also be aware that a programme for the Government include a commitment for the Nature Environment Bill to be introduced during the current parliamentary year. The response for Conferd notes that a commitment to sustainable forestry management and support for efforts to find balanced solutions and respect environmental considerations as part of this. We have received two submissions from the petitioners. The first, which draws our attention to Scottish Environment Linked Strategy to tackle invasive non-native species in Scotland, noting that the forthcoming legislation offers an opportunity to ensure commercial forestry plays a responsible role in managing the impact of sticker spreading from plantations on neighbouring land. The second submission welcomes an update on plans to develop the register of ancient woodland, while raising concerns that this will not necessarily result in additional legal protection for ancient and native woodlands. Do members have any comments to make? Mark Golding.
Thank you, Convener. I think we should close the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government will take action as highlighted by the Convener, and in addition it has committed to bringing forward a Natural Environment Bill. But on that final point, and to hopefully allay perhaps some concerns from the petitioners, I think in closing we should write to the Scottish Government to ideally put on the record their plans for the Natural Environment Bill in terms of timescales. The response we have is due course, and I note that that is similar to the response I received from the Circular Economy Bill, due to be introduced in the 2016-17 programme for government, not introduced till 2023. So that's why I'm keen to at least get an updated response on the timescales for the Natural Environment Bill, which should, in theory, adequately address the concerns from this petition.
Are members of the committee agreed? On that note, we'll close the petition, but can I remind the petitioner, if the Government has not made progress, they can bring a new petition back in the new session of Parliament? Our next petition is petition 1979, establish an independent inquiry and an independent national whistleblowing officer to investigate concerns about alleged mishandling of child safeguarding inquiries by public bodies lodged by Neil McLennan, Christy Scott, Alison Dickey and Bill Cook, who join us in the public gallery this morning, and I welcome you all. We're also joined in consideration of this petition by our MSPs and colleagues Edward Mountain and Ash Regan, and good morning to both of you. The petition calls on the Scottish Parliament to urge the Scottish Government to launch an independent inquiry to examine the concerns that allegations about child protection, child abuse, safeguarding and children's rights have been mishandled by public bodies, including local authorities and the General Teaching Council of Scotland, gaps in the Scottish Child Abuse Inquiry, and establishment of an independent national whistleblowing officer for education and children's services in Scotland to handle these inquiries in the future. I last considered this petition at our meeting on the 6th of March 2024, where we agreed to write to the Minister for Children, Young People and Keeping the Promise, and SPSO and the Children of Young People's Commissioner Scotland. The copies of the responses received are included in our papers for today's meeting. Members will have noted that while the SPSO suggests that there is a merit in exploring an independent national whistleblowing officer role for education and children's services, experiences within the establishment of the NHS whistleblowing service demonstrates that this is not a straightforward process that would require careful design. Response from the Children and Young People's Commissioner echoes the sentiment, noting that while we support exploration of a potential whistleblowing officer role, it is not one that could fulfil by their office, nor do they have any evidence of children and young people wanting the Commissioner to take on such a role. We've also received 2 responses from the Minister, the first of which refers the Scottish Government's determination to ensure robust child protection measures are in place across Scotland through implementing an updated national guidelines. The Minister also indicates her willingness to meet with the petitioners, and I understand this meeting took place on the 4th of December, with the Minister committing to keep the petitioners updated on the work to support more robust and consistent investigation of specific cases. As the Minister has noted in her second response and in response to recent questions in the Chamber, this work includes engaging with the Association of Directors of Education in Scotland about how safeguarding concerns are investigated at local levels, as well as establishing a national public leadership group to discuss ways of public protection process in Scotland can and should be improved. We have also received a number of submissions from the petitioners, which welcome the constructive and thoughtful submissions from SPSO and the CYPCS, highlight continued concerns about fragmented investigation systems and the power imbalance experienced by those raising safeguarding concerns, and the need to ensure those who lived, experience and those issues are part of a designed and independent whistleblowing system. The petitioner's most recent submission comments on their meeting with the Minister. Although welcome the action that strengthens the protection of children and young people, the petitioner remains concerned that the Scottish Government have so far failed to address the fundamental points such as public confidence in child safeguarding, where systems, networks and personnel involved in historic and current allegations of abuse continue to be in place. There's quite a lot of information there, colleagues. So before we begin, can I ask my colleagues Edward Mountain first, then ask Regan if you have anything to say?
Yes, thank you very much, Convener. And I always like coming to the Petitions Committee because there are a wide range of subjects, but this one is a particular personal petition as far as I'm concerned. And it revolves around the question of safeguarding children. And the simple question that we seem to be faced is what cost we put on safeguarding children and whether we think it's right what we're doing at the moment. Now, if I may, Convener, very briefly just allude to a story that I've been dealing with on a constituency level. This related to a child that was approached by a teacher who was making sexual comments and sexual innuendo to that child. The consequence was that the child made a complaint, child left school before they'd finished their schooling, and the complaint took a very long time to go through the Highland Council, and the consequence was the teacher was found guilty. There were complications that some of the investigation was prolonged by the fact that one of the teacher in question had a relationship with one of the people who was investigating it, and the outcome was that the child failed to complete their education. And it's actually worse than that, because it was all a secret story and resulted in the teacher being dismissed and the teacher saying, "I've done nothing wrong" to everyone in the public, and the child being unable to defend themselves because there was nothing made clear. So what we ended up with is a situation where the Highland Council, I believe, misrepresented and didn't carry out the safeguarding responsibilities they had to that child. They ended up marking their own homework, keeping their own results quiet and not publishing them. So the long-term consequences are purely on the child. Now, I struggled with this, and I've struggled with the parents dealing with this because it just seems so wrong. And I find it difficult to accept, which is why I find myself in a position that I absolutely believe that we need an independent inquiry and we need an independent national whistleblowing officer so that parents can make sure that their children are actually safeguarded in the schools. Because at the moment, in my humble opinion, we have a situation that favours the employee because the employer is investigating it, and they then have a responsibility for protecting the employee, however bad they've been, from the outcomes of any inquiries. Now, I raised this with the General Teaching Council in Scotland, and I have to say I didn't find any outcome that was acceptable, which is why I really do believe that this Petitions Committee ought to consider this further and push harder on the government, because, frankly, the answer is they don't know who will do the role, and there's a question about cost, is unacceptable. What cost do we place on safeguarding people? What cost do we place on safeguarding our children? And frankly, I don't think that there's a cost is too high, and we need to get it right. Thank you, Convener.
Thank you, Mr Mountain. Ashrikin.
Thank you, Convener. I just thought it might be useful for the committee to bring some, in a similar way that Edward has done, to bring something to the committee's attention about things that have been going on in Edinburgh City Council. So I had a constituent, I can't go into any details, but I had a constituent come to me, very concerned, explaining about very serious mishandling of whistleblowing, potential breaches of safeguarding of children that had been going on, perhaps in quite a historical nature, that I believe are still unresolved. I think that it would suggest to me, so that is in Edinburgh, but I can see that this possibly goes further across the country, that there appears to be an unacceptably high level of safeguarding failure in the system. And we are talking about children. So I would suggest to the committee that, in the way that Edward has set out, that the cost here should not be an issue at all. That I don't think that the failure in the system is being adequately addressed by the current procedures and processes that are being carried out. I believe that certain public bodies are being defensive in the way that they're interacting with perhaps the Parliament and the government. I think we have seen, certainly over the last week, that the government unfortunately does not have a grip on what is going on across Scotland. And so I also agree with Edward that I think the committee, or I would urge the committee to think seriously about the requests that are in this petition and that they should take them forward.
I thank both my colleagues for their contributions. Do members have any suggestions or comments? Mr Ewan.
Yes, I'm persuaded by what both of our visiting MSP colleagues say, and profoundly believe that the current system is inherently flawed, as the petitioners have maintained throughout the very lengthy sequence of correspondence that I've read in preparation for this meeting. And we have a lot to learn from the Romans, including the very first principle of natural justice, which is nemo judex in causa sua, which means no one can be a judge in their own cause. And the current basis of complaints in the health world, in education, GTC has been mentioned, is that they deal with complaints against their employees. And the first instinct seems to me usually to be to defend the system, the employee, against the complainant. It's almost a genuflection. And I've seen it for 25 years, time and time again. So I'm grateful to the petitioners because I think they've highlighted this inherent flaw which exists, and child safeguarding is probably the most sensitive and most important area that we could possibly conceive of, as both our colleagues have said. I find the cost argument to be utterly unconvincing, and the petitioners have pointed out that the cost of the child abuse inquiry is likely to be £300 million. So the cost of the existing system seemed to me to be what we should be trying to tackle in future, not worry about the cost of a national whistleblower's office, which will be minuscule in comparison to the cost of the damage that has resulted. So I very strongly support this, and I do think we should write to the Minister. If colleagues are similarly minded, then I do feel that we have a sufficient evidential basis, particularly with the lengthy exchange between the Minister and the petitioners. I can't rehash it all, there's no point in doing that, but it's full of very cogent, relevant facts and material, which the Minister hasn't answered in any way. Some of the very modest, minor work that the Minister says is going on, making inquiries about what's happening at the moment, is work that should have been done long ago when the petition was first presented. It's a bit late now. I think there needs to be a whistleblower, and we shouldn't shilly-shally and dither and swither around, but urge the government to get on with it and make that recommendation from the committee. And you know, I do think this is something that is a very widespread concern across parties, Convener. That's the impression that we've had from numerous MSPs that have registered their concerns, and therefore I think we should go off the fence, recommend there should be a whistleblower, and that this should be considered together with the petitioners and others who can provide very useful information about the role, remit and way in which this would operate. It would be very modest in comparison, I think, with the costs, as I've said.
Do other any colleagues have anything else? Mr Chowdhury?
Okay, I agree. I think we should write to the Minister for Children and Young People and promise to recommend the Scottish Government exercise the merit of an independent national whistleblowing officer for education and children's services. Second, update on action the Scottish Government is taking to support more robust and constant investigation of specific child safeguarding case across Scotland, including what consideration has been given to addressing predictive conflict of interest for local authorities between their responsibilities as employer and the duty of care to children and young people. Seek information on what engagement the Scottish Government has had with the UK counterparts following the Home Secretary's announcement that measures to make it mandatory to report child abuse will be introduced as part of the UK Parliament's Crime and Policing Bill, including what consideration the Government has given to introducing a similar measure in Scotland, and to write to the General Teaching Council for Scotland seeking an update on the Professional Students Authority review into its fitness to teach process and the wider work it has undertaken to review the fitness to teach rules, including whether any consideration is being given to perceived conflicts of interest over the role of local authorities as part of the review.
Thank you, Mr Chowdhury. Are colleagues agreed? Thank you. Thank you. Our next petition is Petition 2035, Recognise Legal Control of Generalist Predators as a Conservation Act, lodged by Alex Hogg on behalf of the Scottish Gamekeepers Association. The petition calls on the Scottish Parliament to urge the Scottish Government to officially recognise legal control of abundant generalist predators as an act of conservation to help ground nesting birds in Scotland. The committee will recall that we took evidence from the petitioner last year, and subsequently, at our next meeting on the 17th of April 2024, we agreed to write to the Minister for Green Skills, Circular Economy and Biodiversity. Due to ministerial changes, the committee wrote to the Cabinet Secretary for Rural Affairs, Land Reform and Islands, and has received a response from the Minister of Agriculture and Connectivity. The committee's letter asked about a proposed ministerial statement, research into different conservation methods, funding, zoning and education. The Minister's response reiterates the Scottish Government agrees that predator control can be an important component of species conservation, alongside other techniques such as habitat management and translocation. The Minister's response states that there is no specific information available on the costs and outcomes of each conservation method. The response notes that the efficiency and cost of each method or approach to conservation of a particular species demands on a variety of factors and there cannot be easily compared to on a like-for-like basis. The Scottish Government is currently reviewing the financial support available for agro-environment and climate schemes, and as this review develops, the Scottish Government will consider the funding available for predator control activity. Members recall that the petitioner suggested the use of zoning to allow a target predator control while preventing widespread removal of species. The Minister has outlined work on a generalist predator population survey which aims to better and understand the size and impact of predators on capercaillie conservation and native pinewood restoration. The Minister explains that the outcome of this work will allow further consideration of whether zoning will be useful to allow targeted predator control by preventing widespread removal of predator species. The petitioner has provided a written submission which states that he agrees with many of the points made by the Minister and is satisfied with the answers provided. However, he reiterates his call for a ministerial statement. Do any members have suggestions or comments? Horace Golden.
Thanks. I personally think that a ministerial statement would be very helpful, but as members will be aware, that is ultimately a matter for the Scottish Government and the Parliamentary Bureau. I think the committee's work on this and the petitioner should be congratulated, and I would recommend closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government has, in writing, recognised the importance of predator control in its engagement with the committee and is reviewing the funding for future environment and climate schemes and will consider predator control funding as this develops.
Yes, I've noted that the petitioners said that he was satisfied with some of the answers given by the Minister, and the Minister has taken an interest in this, all of which is to be welcomed. So I think this petition has probably gone as far as it should. I agree that a ministerial statement would be of use, and I would particularly want to support the recommendation that in closing the petition that we do write to the Minister to draw attention to the importance of financial support being available under future agri-environment and climate schemes in order to maintain and increase predator control. I should say I know Alex Hogg is a friend for 25 years, and there's very few people in Scotland who know more about managing wildlife and the countryside than him and many of his colleagues in the SGA, of which I'm a member. I hope I've paid my subscription. But the serious point, I think, is that he's made the case very well for funding. He says the balance over the years that he's worked, which is several decades, between the predator and the prey has changed. Now the predator's got the whip hand, and the prey very often is unprotected, and there's not much that can be done about it. That results in carnage in the countryside for the loss of livestock, particularly lambs, and from foxes and other predators. It's essential that they're properly controlled. And Mr Hogg, in conclusion, makes the point that he thinks that if there is a particular specific strand in the new agri-environment schemes, that would not only help them control predators that cause enormous damage and worry and stress to farmers and crofters and land managers, but it would also enhance some of the species that are under threat as well. And he makes that point in his submission.
Has everybody agreed to recommendations? Thank you. The next petition is petition 2056, introduce legislation allowing the Scottish ministers to intervene on the hire of public land, lodged by Stephen Gould. The petition calls on the Scottish Parliament to urge the Scottish Government to introduce legislation providing ministers with the power to call in and potentially override Council's decisions on the hire of public land for large-scale events. We last considered this petition at our meeting on the 6th of March 2024, where we agreed to seek the views of COSLA, Association of Public Service Excellence in Scotland, Event Scotland, the Scottish Tourist Alliance and the Scottish Showman's Guild on the ask of this petition. Responses from Event Scotland and the Association of Public Service Excellence are similar to views previously provided to us by the Scottish Government, that local authorities are the best placed to make decisions about the hire and use of public land, with APSE highlighting that such decisions are subject to judicial review and any disputes regarding decision-making would be for the courts to adjudicate on. COSLA responds to let us know it is in no position on this matter, but suggests that we might want to contact the Society of Local Authority Lawyers and Administrators in Scotland for reviews. And the Scottish Tourist Alliance responded to say it believes, and I quote, where there is no sound reason given in refusing the hiring of the land for events and there is clear case that it delivers a positive local, regional and national economic impact, it be fair that the Scottish Government could have a power granted to challenge a local authority's decision. Response goes to state that it is important that there is an open and transparent dialogue with local authorities and others, including businesses, to reach an informed decision if an event is to take place. We have also received submission from a petitioner commenting on the various responses received and setting out his views that the hire of public land is separate to council licensing procedures, which comes into effect once permission to hire land is granted. Do any members have comments? Mr. Ewan.
Yes, I do think that that the evidence that we've had from the Scottish Tourism Alliance, which you've helpfully read out to us, convener, is something that should be pursued, namely the recommendation that the Scottish Government should have power to challenge a local government decision. I do think that that's something that we need to explore further. Just going back to reread the petitioner's comments previously, you know, he says he was fobbed off with various excuses, and there hasn't really been any answer to that. On one occasion, he was told that he couldn't use the land because someone else might want it. Well, I mean, for goodness sake, what sort of an excuse is that? So, you know, I think given the Scottish Tourism Alliance, I know, represent a huge range of tourism bodies, their voice, convener, is significant. The fact that they've chosen to respond with this very specific suggestion is one that I feel that, to be fair to the petitioner, we should pursue further rather than close this petition at this juncture. It may be that the Scottish Government refuse to do this. I wouldn't be surprised were they so to do, but I think we should at least ask them.
Okay. Our next petition is petition 2058. Require all dog boarding kennels to install smoke detectors, smoke alarms and sprinkler systems, lodged by Julie Loudon. The petition calls on the Scottish Parliament to urge the Scottish Government to improve fire safety within dog boarding kennels by mandating the installation of smoke detectors, smoke alarms and sprinkler systems. We last considered this petition at our meeting on the 21st of February 2024 and agreed to write to the Scottish Government, COSLA, the Scottish Fire and Rescue Service, Edinburgh Dog and Cat Homes, Dog Trust and other relevant stakeholders. The committee has received a response from the Scottish Government, COSLA, Scottish Fire and Rescue Service, Edinburgh Cat and Dog Homes Trust, Dogs Trust and Pet Industry Federation, and the petitioner. The Scottish Government is considering revoking the Act that currently regulates animal boarding and bringing boarding under the Animal Welfare Licensing of Activities Involving Animals, Scotland Regulations 2021. Its response to the committee states that the Scottish Government will consider how to address fire safety under any future licensing scheme. The Dog Trust stated it supports the bringing of animal boarding under the scope of the 2021 regulations, noting that it hopes to see the creation of guidance under any new legislation for boarding establishments that mirrors the animal welfare establishments guidance as a minimum. The Scottish Government submission also states that in light of the incident highlighted in the petition, animal welfare officials will seek to engage with colleagues in the Fire Protection Safety Unit to identify appropriate enhanced fire safety measures and how to best incorporate these measures into any future licensing scheme for animal boarding. Stakeholders raised concerns about the practicalities of requiring sprinkler systems in dog boarding and rehoming kennels. Dog Trust consulted on a contractor who gave a rough estimate of tens of thousands of pounds to install a sprinkler system at one of their centres. The Pet Industry Federation sought views from kennel category members across Scotland All respondents said that they have a smoke detectors on top of fire extinguishers required, and none had sprinklers installed. Respondents were open to suggestions of installing sprinklers. However, some raised concerns about the cost and economic viability of installing a sprinkler system in commercial boarding premises, where it being practically impossible in some cases. The Federation concluded that the cost of installing such a system is likely to be too high for many, and it would be difficult to support an additional requirement which would potentially put its members out of business. The Scottish Fire and Rescue Service responded provides figures for fire incidents since 2009, and 24 fire incidents were recorded under the relevant category for animal boarding and shelter kennels with dogs. Of those incidents, 4 of the premises were noted to have had smoke alarms present. The submission notes that under fire safety law, the measures need to be taken to address risks, but do not extend that the cost, effort and other disadvantages associated with the provision of fire safety measures would be disproportionate to the risk of life. Do members have any comments or suggestions to make? Maurice Golden.
Thank you, Convener. I think the committee has created a body of evidence around this which is very useful, and I hope the petitioner is satisfied with the action that has been taken. But in that regard, I think that unfortunately we now need to close the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government is considering bringing animal boarding regulation under the Animal Welfare Licensing of Activities Involving Animals Scotland Regs 2021, and, if progressed, would consider fire safety as part of that work.
Are members agreed? Thank you. Our next petition is petition 2065, Improve and Prioritise Pedestrian Safety, lodged by Sean Rafferty. The petition calls on the Scottish Parliament to urge the Scottish Government to improve and prioritise safety for pedestrians by widening pavements and reducing street clutter, introducing a mechanism to report pavement parking, and improve visibility for pedestrian crossings. We last considered this petition at our meeting on the 6th of March 2024, where we agreed to write to Transport Scotland and COSLA. The response from Transport Scotland pointed that the National Planning Framework 4, which states that one of the 6 qualities of a successful place is a well-connected with networks which make a place easy to move around. This includes designing for pedestrian experience, including safe crossing, pedestrian priority and reduce street clutter. Transport Scotland also states that this is for local authorities to identify streets that are in need of decluttering and utilise available funding to improve safety on street. Similarly, the response states that local authorities are responsible for the day-to-day enforcement of pavement parking ban, and it would be a matter for each local authority to decide whether it sets up its own reporting system. Regarding the visibility at pedestrian street crossings, the guidance on crossings designed is provided in UK guidance which sets out key points for consideration so that pedestrians are able to see and be seen by approaching traffic. COSLA's response to the committee notes that it supports the shared goal to eliminate road fatalities and casualties by 2050. However, the response notes the unprecedented financial pressures on local authorities and noted that these pressures impact Council's ability to implement these improvements. Do members have any comments or suggestions? Ferguson?
I do think that we've probably pursued this issue as far as we can at this stage in the parliamentary cycle. So I would recommend that we close the petition under Rule 15.7 on the basis that of four factors. Firstly, that guidance on the visibility of pedestrian crossings is set out in UK-wide guidance on the design of pedestrian crossings. The National Planning Framework 4 highlights safe crossing, pedestrian priority and reduced street clutter as desirable qualities. The Scottish Government considers it for local authorities to identify streets that are in need of decluttering, and the day-to-day enforcement of the pavement parking prohibitions, including consideration of reporting systems, is also the responsibility of local authorities. So, taking account of those factors, I would recommend closure of the petition.
Thank you, colleagues. We now move on to agenda item 3, consideration of new petitions. Before I introduce the first new petition, I should begin by highlighting to those following today's proceedings that as a considerable amount of work is done in advance of considering of a petition. Before a petition is first considered, an initial view is sought from the Scottish Government and a briefing from the Parliament's impartial research service provided. Our first new petition is Petition 2121, run a targeted roadside litter awareness campaign launched by Caroline Phillip, who I believe may be with us in the gallery today. Welcome to you. The petition calls on the Scottish Parliament to urge the Scottish Government to run a campaign targeted at companies to raise awareness of the harms caused by roadside litter and the penalties that could be brought against responsible parties. And we are also joined for consideration of the petition by our colleague today, Rachel Hamilton. And welcome, Rachel.
Thank you.
Keep Scotland Beautiful reports that 50 tonnes of litter is abandoned on Scotland's roadside each month. The charity's annual Scottish Litter Survey of 2024 set out that 88% of respondents viewed roadside litter as a problem in Scotland. The Scottish Government's response highlights the 2023 National Litter and Fly Tipping Strategy and Year 1 Action Plan. The response states that this work recognises the importance of prevention through education and communications and effective approaches to enforcement. On the issue of enforcement, Section 18 of the Circular Economy Scotland Act 2024, when commenced, will enable the issuing of civil penalties for littering from a vehicle. The response informs us that the National Littering and Fly Tipping Strategy Delivery Group has established a communication subgroup that will be exploring the best ways to deliver communication messages effectively on litter and fly tipping. The proposals put forward in the petition will be shared with the subgroup so they can consider them as part of their ongoing work to look at improving communications at a national level. However, the Scottish Government has indicated that a direct mailing to local businesses and roadside signage would be a matter for local authority or Transport Scotland. The petitioner has responded, stating that while her group commends the amount of work done in producing the action plan, it does not agree that the fundamental steps have been taken to address the point made in the petition. She points out that the action plans does not mention making companies responsible for securing loose items and open back lorries. The petitioner states that large sums of money are spent each year to clean litter and suggests that this money would be better spent on applying a workable and enforceable way of reducing litter in the first place. Before I invite comments from the committee, can I ask Rachel Hamilton if you'd like to contribute today?
Yeah, thank you, Convener. I'd like to thank you and the committee for giving me the opportunity to speak today in support of petition PE 2121 to run a targeted roadside litter awareness campaign. I'd also like to share the convener's welcome to the petitioners Carolyn and Myra from Berwickshire Anti-Litter Group to the public gallery. The Berwickshire Anti-Litter Group regularly coordinate litter picks throughout Berwickshire, including on the A1, which is one of the main tourist routes into Scotland. I'd also like to welcome around 30 other litter and gardening groups who are watching online. Members of the committee will be pleased to hear that groups from their own constituencies and regions, such as West Lothian litter pickers and Dundee litter pickers, are amongst those watching online. We all know, committee, that volunteers like Candy and Myra give up their free time to pick litter from the goodness of their heart. They choose to do this with very little support from anyone, including the Scottish Government and cash-strapped local authorities. Between March and April 2024, Keep Scotland Beautiful held their annual Spring Clean, which saw 45,000 people from every local authority across Scotland take part in 3,564 registered litter picks. And those volunteers care deeply about the communities they live in. They also recognise the importance of protecting Scotland's biodiversity through maintaining the cleanliness of our environment. Recent stats reveal that just over 4 in 5, that's 82% of people in Scotland, agree that they want to see more efforts to prevent litter in their area. And a similar figure, 81%, express a desire for increased action to clean up litter locally. Carolyn Wilson, the lead petitioner, has said that for 3 years they've been writing to local councillors, government ministers, Bear Scotland and Transport Scotland. She says that their responses have been patronising, thanking them for their hard work, but not providing any positive or constructive solutions that are enforceable. Despite the Scottish Government publishing the aforementioned by the convener National Litter and Fly Tipping Strategy, the landscape of who is responsible for collecting roadside litter, enforcing penalties and raising awareness of the issue remains confused and scattered. Furthermore, pace and action by the Scottish Government is glacial, meaning that the blight of litter continues to have a significant negative impact on communities and our environment. I will come to a close, but finally, Keep Scotland Beautiful admit that we've reached the point where there is a litter emergency and that without increased coordination and attention on the issue, this current situation is unlikely to change. I agree with Carolyn when she says that we need definitive action, not more talk. On that note, I will close by saying that I would like to add my full support behind the aims of this petition, and I hope you, the committee, will give it due consideration. Thank you.
Thank you, Ms Hamilton, for your contributions. Do members have any suggestions or comments? Maurice Golden?
Thanks, Convener. I think there's actually quite a lot in this, and I think it might help the petitioner if the Scottish Government could provide the context of roadside litter awareness campaigns and who has been responsible for delivering them over the period in which the Scottish Government have been in charge since 2007, I would suggest. And it would allow the committee to have that context. So what I would like the Scottish Government to detail is who has been responsible for any specific campaigns, and aware of one from Keep Scotland Beautiful from 16 to 19. But I'm also aware that there's been varied responsibility for delivering litter awareness campaigns more generally, such as, I think, 2011, there was Dinna Chuck Bruck, a Shetland-based litter awareness campaign, which I think I might have to declare an interest because I funded them. But I think it's very important, the Scottish Government, each year, how much funding has gone into roadside litter awareness campaigns. If they've been generous, they might expand that to litter campaigns. Who's responsible for delivering it? What was the assessment of the Dumb Dumpers phone line, which was a national phone line, which now if you call, you get redirected to call your local authority, which isn't necessarily set up around this. I think, as well as asking the Scottish Government for further information around the National Litter and Fly Tipping Strategy, delivery groups, communication subgroups, what a mouthful, including what actions will be taken to improve communications and littering at a national level, which I think is critical. This isn't purely a local authority issue. And what engagement has been done with stakeholders involved. I think it's also worthwhile getting a response around the littering provisions in the Circular Economy Scotland Act 2024, if they will cover unintentional littering from commercial vehicles. I hope they will, because the Circular Economy Act will not deliver a circular economy, so if it doesn't deliver on litter, then it's doing very little. I think it might be interesting to look at other stakeholders who could have an interest in this beyond the Scottish Government. I think the member highlighted, those that manage our trunk roads, including Transport Scotland, and I know from paddleboarding under the Friarton Bridge how dangerous roadside litter can be, because lots of individuals will throw various aspects out. Final point for the Scottish Government, as a result of extended producer responsibility, I wonder how the Scottish Government is engaging with producers to help coordinate litter and therefore reduce disposal costs, which I know many of the large companies and small producers are very keen to do as a result of extended producer responsibility. I think that's me.
Thank you for that very comprehensive submission there. Is members agreed?
I'm impressed by how much Mr Golden knows about rubbish. On that note, Mr Ewan, we will move to the next petition.
Our final new petition is petition 2124, Keep Private and Workplace Pensions Out of Divorce, lost by Eliza Wyburn. The petition calls on the Scottish Parliament to urge the Scottish Government to change the law to no longer consider private and workplace pensions as part of a matrimonial property. As Spife Breeson explains that pension benefits built up during the period of a marriage or civil partnership are considered matrimonial or partnership property. The briefing also notes that a key principle of financial provision on divorce is that the net value of a couple's matrimonial or partnership property must be shared fairly between them. Fair sharing is usually equal sharing unless specific circumstances apply. The Scottish Government's response to the petition states that it does not support the aims of the petition. In response to the petitioner's view that no contribution is made by a partner to a pension, the Scottish Government highlights an indirect contribution made, such as one spouse leaving or reducing paid work to care for children or other family members. The petitioner's written submission shares her view that staying at home to look after children is a choice of an individual and highlights the childcare funding proposed by the Scottish Government. Petitioners keen to receive more data on the issue raised in the petition, and do members have any comments or suggestions for action? Mr Ewan.
Well, thank you, Convener. I've tried to consider this petition very carefully, and I should say that as a solicitor formerly in private practice for a quarter of a century, I did deal quite a lot with matrimonial work and financial settlement and divorce, which is covered, as the Minister has said in her reply, by the Family Law Scotland Act 1985. And one understands that both parties to divorce usually have very strong feelings and very often feel that the division of the cake is unfair. And one can sympathise with that in certain circumstances. But I do think that the government has set out very clearly that it is not in favour of this policy, and there is really no prospect whatsoever it's going to change those principles. I would say from our own experience that the Family Law Scotland Act 1985, I think, is a very good piece of legislation. And I just wanted to make one specific point clear, which may not be immediately apparent, but that the assets that fall to be divided between the parties under the Family Law Scotland Act are classified as matrimonial property, and that is property brought into anticipation of marriage, or property that is acquired or created during the period of the marriage, from the date of the marriage until the date of the separation or raising of the writ, if there hasn't been a separation. In other words, the point is that if a couple, if one gets married at, say, 50 and then divorces at 55, and you've taken out a pension when you were 25 and you've still got that pension, then only the proportion of the pension attributable to the time period relating to that date of the marriage to the date of the separation falls to be taken into account. And that's because it recognises that there needs to be a recognition of the contributions of both parties in bringing up children and so on. If there's one breadwinner, the other spouse may very often have substantial child-caring responsibilities, usually not always the female. So I think the law is quite sophisticated. It seems to me to have stood the test of time. I think it does seek to be fair, and whilst the petitioner feels it's unfair, I'm not persuaded by her arguments. And on this occasion, and I'm not saying this for, I haven't said this for a while, I do agree with the Scottish Government.
Thank you on that. Are you suggesting we close the petition under Rule 15.7 of Standing Orders?
I know the petitioners will always be disappointed, but as you said in a previous petition, a lot of work has been done up to this time by the clerks, getting a response from the Minister, getting the response from the petitioner, and were there any prospect of any reform, it would be our duty to explore and examine that, I think. But my own personal view, and members may take a different view, is that there is no prospect at all of the Scottish Government changing its mind. If there's a different government in the future, the petitioner might wish to bring it back if she so wishes.
Are members agreed? Thank you. And that concludes the public part of our meeting. And our next meeting will take place on Wednesday, the 19th of February. And can I hope that our convener is well enough to convene the meeting then. So thank you, everyone.